the Bald Oncologist podcast series, featuring Dr. Malwinder.
Hello everyone, welcome to the Bald Oncologist podcast series. Today in our studio we have Consultant Thoracic Surgery, Dr. Nara. He's actually one of my machas from Sungai Petani and Alostar days. We've been working together for quite some time. Okay, so welcome Dr. Nara to our show.
Yeah, those were the days in Alostar.
Yeah, those were the long lost days.
Yeah.
Okay, so Macha, tell me a little bit. I want to talk a little bit about lung cancer. So our previous podcast, we did discuss about low-dose CT and lung cancer screening. So what do we do when we find there's actually something wrong in the CT scan, like a lung nodule or something? What is the next step?
Well, when you find these lung nodules, especially when we start doing low-dose CT scans, you ought to find a lot of nodules in our population especially.
Yeah, actually, right. Sometimes in normal CT scan also, you actually see a lot of lung nodules.
Yes.
And I always tell my patient, you take 10% down the street, right? You just scan 5 of them will sure have lung nodules.
Sure, because we have very high tendency to get this tuberculosis.
Correct.
And also some infections due to the pollution, and that's whatever is going on. So you tend to find these nodules. And the problem is, how do we know these nodules are malignant or not malignant? That's the challenge that we face in day-to-day practice. So it all depends on the size of the nodules that we detect. If the nodule is, say, for example, less than 1 centimeter, or 1 to 2 centimeter, or more than 2 centimeters. So the real challenge is actually whether can these nodules be biopsied. If these nodules can be biopsied, then it's quite straightforward. Do the biopsy of the nodules and then see what the pathology report comes back. If it is malignant, then we can stage the patient and then subsequently plan the surgery.
So is there any size which we can biopsy?
If the nodule is more than 2 centimeter, usually the ease to biopsy these nodules is much better. The yield that can be garnered from the biopsy is much higher, and you can get a proper conclusive diagnosis.
Okay.
And as compared to if the nodule is about 1 centimeter, when the biopsy is performed by the interventional radiologist, what will happen is that the chances of the needle to hit the epicenter of the tumor is less likely. And that translates to lower yield of tissue diagnosis. And it's even worse if the nodule is sub-centimeter.
Yes.
So conventionally, what was told, all these guidelines are, so what they say is that repeat CT scans in 6 months.
Correct.
Okay. So when you see that what we are looking at in 6 months' time is a doubling time of the lesion. But in these days, when we have moved forward in terms of our technology and imaging, there are other methods that we can use to diagnose this rather than waiting 6 months to repeat CT scan.
So this is where you come in with minimally invasive surgery.
Okay, it is a multidisciplinary thing. I cannot work alone.
Correct.
I cannot work.
I also can't work alone.
Yeah. So I need my, as a surgeon, in order to do this small lesion biopsies. Small lesion meaning less than 1 centimeter or 1 to 1.5 centimeter. And it's difficult to reach areas near the heart, near the major vessels, near the diaphragm. So it's difficult for the intervention radiologist to target these lesions. So in these situations, what I can offer as a surgeon is that we localize the lesion with a dye that can be seen intraoperatively using a minimal access manner. So when you localize this lesion, we call it, we use indocyanine green dye. Okay. This dye is activated when you look at the lesion under the infrared view.
So you actually inject the dye to the tumor or just spread it?
I don't inject it.
Okay.
My friend, interventional radiologist,
okay,
will bring the patient to the CT suite under general anesthesia, inject the dye into the tumor. Once the injection is done, then we will bring the patient up to the operating theatre in the same setting, and we will make a small incision, it's about 3 to 4 centimeters in the chest wall, and we'll activate the infrared view from the telescope, and that will show the localization of the nodule. So this will enable me as the surgeon to resect the nodule and send for frozen section. So that's the next discipline that I'm involved with, which is my pathologist. So in the same setting, I need my interventional radiologist, pathologist, and myself to make sure that these processes executed successfully.
Okay.
And the pathologist will tell me within half an hour whether am I looking at a malignant lesion or a non-malignant lesion.
Okay.
If it is not a malignant lesion, the surgery is over. I close the patient up and tell the patient the good news once he wakes up. If it is malignant lesion, then I have to do a definitive surgery. So in these days, we have got evidence to show that if the lesion is less than 2 centimeters, you can do sub-lobar, meaning you don't have to take out the whole lobe, you can take out part of the lobe, and you can still achieve oncological clearance.
So that tissue which you remove for frozen section, that is not considered a good surgery. You still need to resect a little bit more.
Yes, because you see, oncological principles must be adhered in these surgeries, especially if it is a malignant lesion. And if it is malignant lesion, there are intersegmental nodes that we need to address.
There's a lot of lymph nodes here.
Yeah. So if you just do a wedge resection with a clear margin, well, it is adequate to a certain extent, but the evidence shows that the recurrence rate is higher.
Okay.
So if you
Fair
need
enough.
to do a segmental, means anatomical sublobar resection, delineating the segments and removing the nodes along with it, and that will give proper oncological resection, and the patient will be deemed cured pending the histopathological report.
Okay.
And that is all done by minimal access manner through a single hole measuring about 3 centimeters on the chest wall.
So even just a 3 centimeter hole, which is at the side of the chest wall, you can actually reach to the edge of the lung.
Yes.
And during that whole frozen section, half an hour, what do you do actually?
I'll
Drink coffee?
Well,
Play
it
for-
depends. If the pathologists that I work with, normally they can deliver the results within half an hour. But we also have some challenging cases where they need longer period of time. So in this situation, I might just go for a coffee while the patient is still under anesthesia.
Okay.
And I pity my anesthetists, they have to be with the patient.
It's okay, you work very hard, you can take a break sometimes.
So once the result is back, then we don't have to bring the patient out of the operating theatre. In previous situations, you need to go for a biopsy. That's one procedure. The patient have to get into the hospital, biopsy. Maybe have to observe for any pneumothorax or bleeding after the biopsy. That go home, wait for the result for 3-4 days, come back, then plan the surgery again. And that will take about another 2 weeks before the actual surgery takes place. In this situation, you don't have to do that.
Okay.
And another common question that is asked by most of my patients who agree to this kind of arrangement is that, doctor, if I do the biopsy, because I always advise them to go for a biopsy first. If I do the biopsy and the biopsy comes back as not malignant, am I going to let the lesion inside my lung? So I said, that's up to you. Because if it is not malignant, then there's no business to take it out.
Remove it, yes.
But most patients will say, no, they're not comfortable with it. They want it to be out. So they rather go for a one-stage procedure where I can wedge the lesion, remove it completely, check under microscope. If it's malignant, we do a definitive oncological procedure.
Okay.
If it is not malignant, close the patient up, and he wakes up, he knows that the lesion is normal in his lung.
In his lung. So he feels more secure.
Yeah.
Ah,
And no anxiety after that.
correct. So in that 3 centimeter incision which you make, is there like a maximum size of tumor? Or it has to be like small tumor that only you can use that 3 centimeter?
Usually we try not to go more than 5 centimeters.
Okay.
So because lung is something that is air space that can expand with air in it, and if there's no air, it'll collapse.
Yep.
So the whole lobe can be the size of a fist. And when you put it in a bag, the lobe can be squeezed out from a 3 centimeter wound.
Okay, so you can actually compress the tumor. Oh, that's interesting. So people who do this minimally invasive surgery, I'm pretty sure there's only a few in these countries. Is it routinely done everywhere?
Well, it depends on the practice of individual surgeons. There are not many surgeons who perform uniportal, means single hole minimal access surgery.
Okay.
There are surgeons who are performing multiple hole. Actually, there's not much difference between these two methods. You can either do single hole or multiple hole. It depends on the surgeon's preference and whether the patient likes the surgeon's face or not. You see? So there's no hard and fast rule whether you must do uniportal. That's the trend, but no. But minimal access surgery is proven to be a gold standard for lung nodules, which is supposed to go for surgical resection.
Okay, and I think the complication rate is much less. The stay in the hospital is much less.
Yeah, they return to their normal daily activity much faster.
Okay, that's interesting to know. So, Mr. Nara, is there anything you would like to tell to the public?
Well, what I'd like to emphasize to the public is that lung cancer is number one killer in the world, and we need to address it very seriously. And one of the main way that we can deal with lung cancer is by performing early detection, like what was mentioned in the podcast earlier, is by performing low-dose CT scan. And by doing the CT scan, nodules can be detected, and we have avenues and approaches and methods that we can deal with small lung nodules in these days. So I would like to thank the Ball Oncologist.
Thank you.
My old-time friend, Dr. Malwinder, for giving me the opportunity to highlight these issues in his valuable podcast.
Thank you.
Thank you.
The Bald Oncologist podcast series